My name is Thifhelimbilu Luvhengo. I'm from South Africa, and originally where I was born is what we now call Vhembe district of Limpopo province in South Africa, just next to the border with Zimbabwe. But all my university life was spent in the province of Gauteng province, which is my universities are based in Johannesburg. I trained at now called Sifako Health Science Universities, and after that I spent 10 years at the University of Pretoria, and this is my 11th year at the University of Witwatersrand. But despite that, I have been actively involved, and I'm also part of endocrine surgeons of South Africa, and which we're trying to launch a Pan-African Endocrine Surgeon Society, and I've done more than 1,000, if not more, thyroidectomies, because when I practice in my rural area, thyroid goiter was the most common pathology, and the patients in our setting tends to present with huge goiters, and so if you want to learn how to do a thyroidectomy, actually come to my village, to my rural area. And of course now with iodinization of salt since 1995, what we are starting to see now is more an increase in papillary carcinoma of the thyroid. We used to see more follicular carcinoma of the thyroid, and the next bit of surgery that I do is a parathyroid surgery, and in maybe because of diagnosis, we don't seem to see a lot that is described in other countries. So if we do 30 parathyroid in a year, that's a lot. But we have centers a bit in Australia, in the US, in India, where they're actually doing parathyroidectomy almost every week, 2-3 every week. And of course, we also have got adrenal surgery for adrenal tumors. And maybe I would summarize now before we get into other areas, is to say, key to thyroidectomy is to do a complete operation without complications. Open surgery, for example, we talk of a learning curve and a high volume surgery. That ideally you should be doing more than 50, but if it's 30 thyroidectomy per year, that is fine. Now, and so that training should have started initially seeing others doing it, and going to simulation if you have, and more so if you are now going into endoscopic or a robotic. There has to be a lot of training in advance, so you can't start from reading the books or seeing somebody doing it and automatically then jump to be doing the first patient. So there has to be some simulation in the lab. I'm so glad that most of the training centers now have got the ability for those simulation labs where students train. And even when you're now doing it, the beginning is not to do the entire procedure. Is to say, let the easy part, putting the pots, positioning the patient, putting the pots, making the dissection. And then the next step is to now then go to separation, the strap muscle, dissection of the recurrent laryngeal nerve, checking the parathyroid. So it has to be stepwise, and also it has to be an appropriate case. Our majority of thyroid goiters that are presenting in my setting will not be ideal for peroral thyroidectomy, because these are huge and also if your patient has got extensive lymphadenopathy, or you're dealing with a recurrent, sometimes we have to redo surgery, which was not done properly, or if it's a goiter due to iodine deficiency, with time, if the operation was not total, it recurs, and you should not be trying to do this type of procedure for redo, because the dissection planes have been altered. Actually, in the modern treatment of parathyroid and endocrine and thyroid, I do not think any patient should be touched and we start treatment without an ultrasound. Whether you are dealing with a toxic or you are dealing with a euthyroid goiter, one is able to dissect the central lymph nodes, that is level 6 and 7. Now, I will not venture into dissection of the lateral lymph nodes. So if I haven't done an ultrasound and I go and operate, I'm going to be giving this patient an inappropriate procedure because you have left the disease. So that's why absolute ultrasound for any endocrine problem, except perhaps for adrenals, because CT scan there. But in the neck, you should be starting with an ultrasound. It's going to tell you about vascularity. It's going to tell you about lymph nodes. It's going to tell you about how is a contralateral side normal or abnormal. And as I've said, you want to be looking at the lymph nodes and characterize them as to whether they've got features for malignancy. So that's the ultrasound is a must do. The complications that we would expect from the standard open thyroidectomy are still applicable to this procedure. The next complication is removal of parathyroid, or disturbance, because sometimes go into shock because of the electrocautery that we use, or devascularization. So that can be permanent or transient, the same as recurrent laryngitis. So those two complications are still there. The third one is damage to the superior laryngeal nerve, the one that controls the pitch of the voice, where the patient is able, can talk, but says, I used to rely on singing, doctor. Now when I can't sing, because you need that nerve to be able to vary the tension of the vocal cords. And so those are still there. And the issue of bleeding is still there, though reduced. This procedure magnifies the vision, but you can still bleed. But the complications that are quite specific for this, because you're now operating at a different site, there's an extra nerve, the mental nerve, that is not there in the neck, and of course the next thing that you would have, you are insufflating carbon dioxide, and working in an environment where there are veins, and those veins, because of the positioning of the neck, to reduce bleeding, you need a bit of up. The head should be a little bit up at the neck, and so the JVP is down, so veins are sort of open. Other issue, of course, you are using electrocautery. You are working just under the skin. You can actually cause burn and hematoma under the skin. So that's why I said you are running away from cosmetic issue, but you may end up with a worse cosmetic situation. So it's not something that should be tried without repeated practices. And I think this should also be covered in the informed consent. So when you're doing this operation, you warn the patient of the possibility that though you don't want the scar in the neck, there's a possibility that but the benefit, because you can do this procedure by operating from under the breast or from the axilla. But what this approach provides is that you are very close to the site of the operation, so those are the complications that we're dealing with, which of course there are measures to try to reduce them. The evaluation of a patient with a goiter, we just do think, is there features of hyperfunction or features, is it normal function? If there is no features of hyperfunction, and so there's euthyroid goiter, there you are saying that your diagnosis should just be fear of malignancy. That's what you should be ruling out. And what do? You evaluate the patient, the disease, the patient, the family, and the environment. Are there things from those components which are suggesting to me that this patient is a high risk for malignancy? For example, from the disease, is rapidly growing. It is associated with a hoarse voice. And then from the patient, is a patient who has had previous radiation. Is a patient who has got other manifestation, for example, multiple endocrine neoplasia. This should be associated with medullary carcinoma. Now that this patient has got manifestation, for example, no patient with a goiter should be hypertensive. If there's hypertension, I must rule out is the goiter not medullary carcinoma of the thyroid? When I go to the family, I'm also checking family history of malignancy, family history of men. Is a patient coming from an environment where there was radiation issue? Is the patient coming from an area where which is iodine deficient or iodine replete? Those are the things that I consider. When I evaluate the neck, again, I'm going to check features of hyperthyroidism. I'm going to check, are you dealing with a nodular goiter or diffuse goiter? If it's nodular, you should be worried of malignancy. And then I look for lymph nodes and the forehead. And the first investigation for all thyroid should be TSH. And if it's abnormal with no symptoms of hyperthyroidism, then I have to do T4, T3, because I want to check if it's subclinical. But otherwise, if TSH is normal, I don't. And I've already said no patient should be denied an ultrasound investigation with thyroid problem, because that is after thyroid function. If it's hyperthyroidism, you see it with increased vascularity. And that increased vascularity, you will then check, is the inferno, this increased vascularity localized, or is the whole thyroid? Then it's Graves' disease. And then if it's euthyroid and nodular, then you characterize all the nodules that you see according to whatever system. Are you using the Korean TIRADS? Are you going to use the American Thyroid Association, a radiological assessment to say, does it have features suggestive of malignancy? So a lot of this can be done by a general practitioner. And what the general practitioner should actually be saying, strong radiation history, but the SONA says, doctor, don't worry. And a TSA says, doctor, don't worry. You cannot accept that because there's a mismatch. And so those are the patients who, at the end, you say, these patients goiter, that's euthyroid, I'm not finding anything. I need to refer because this patient will probably need a diagnostic lobectomy. And so that's the wake up. And fortunately, the thyroid cancer, if it's treated well, the life expectancy, 95%, 20 years survival. So we're not worried about death due to thyroid cancer if it's treated appropriately. So that's why even the operation that you perform, you must make sure that you're getting the disease followed by radioablation. And so if it's beyond the transoral, thyroidectomy, then you say, this one I'm not going to do it. So the general practitioner can give the options to say, I think this is what they're going to do. The options are this and this and this. And also a talk of the possible complication, but not scare the patients and say, the cut in the neck and you're going to have there's a possibility that your nerves will be injured and you will not be able to talk again. In our setting, close to 70% of amputations now are due to diabetes. And we all know that the leading reason for amputation in diabetic patients is septic food. Now, you are right that currently what we are prioritizing is just to cutting off the legs, and we send the patient home, and they come back to cut the other one, or make the amputation higher, or cut the opposite leg. And 50% of those patients are dead within 3 to 5 years, those who have been amputated. So it was interesting. Before COVID started, we had a colleague, and they said they had this crisis, and they decided they ended up reducing the impact by 95% by using the podiatrist. So any patient who is diagnosed with diabetic is considered to be having a foot at risk, and they using the zip codes, they were able to map in Glasgow and to say, so because they would do a podiatric. Now we have got the computerized where they assess your foot and say, does it have, and with this foot mapping of your foot, they are able to grade to say this person has got a stage 1, stage 2, up to stage 4, and now you have got a system of, after analysis, that computerized program actually prescribe if you need a shoe for pressure release or pressure dispute, they're able to for equal distribution of foot pressure. The machine just tell you, and I think that's where we need to go. We need to be investing on podiatrists. We need to be investing in preemptive evaluation of this foot, and if there's excessive pressure on the big toe because of the neuropathy of diabetes that have affected the eye, then we prescribe a foot relief. And that is less expensive rather than waiting for ulcer to. Even some patients in our setting, the ulcer has already developed a prosthesis or appliances, and we wait until that ulcer gets infected. And when it gets infected, some of them are coming from rural areas. The intervention is not timeous, and so. And even after we amputate them, there is no referral to occupational therapy or physiotherapy. They just go home. Majority of them don't go back to work. And on top of that, as I said, majority of them are going to be dead in 5 years. And those are the issues. And it also gives us an opportunity, because that patient who is coming with a foot having a problem is likely to have kidney problem, diabetic nephropathy. Is likely to have diabetic nephropathy. So if we package that care and make sure that we include the podiatrist, we include the dietitians, we endocrinologists, and a surgeon should not be the primary player in diabetic food, but we are the primary player because we're just waiting with our knife. It's depressing. New technology, and it may be expensive initially, but we should also be investing, and to also be involved in teaching. We should fight for a space to teach endocrine surgery to pre-graduate students at any level. We should be actually be talking to the community, awareness for endocrine issues, and also we should also be preparing ourselves that endocrine problems are going to increase. Currently, thyroid cancer is the commonest endocrine cancer. And we know that it's increasing. It's just how you pick it up. If you were to do ultrasound in 100 of us, you're going to find nodules in probably 30 out of 100. And out of those, 5 to 7, depending on the age group percent, is going to be having a malignancy. And it is increasing. So that is a field that we need invest in future leaders in this area, future leaders who are embracing technology. I would want a lot of research happening. The genetics of thyroid cancer. I want to see a lot of PhDs being done in this field, and that we should be able to outcompete everybody else in endocrine surgery, not for fun, just because this is a common problem, and it's very essential. Thank you.